Think about a normal infection for a second. Usually, given a little time and the right antibiotic, your immune system eventually finds it and clears it right up. But infective endocarditis, yeah, it is entirely different. And understanding exactly why is absolutely crucial to mastering this whole topic. The bacteria responsible for this disease do something incredible and honestly incredibly dangerous. They build a physical fortress right there on the heart valve. It's an impenetrable shield that your white blood cells and even our most powerful antibiotics can barely get through. This infection behaves like literally nothing else you'll encounter. And today, we're going to build the complete clinical picture from the ground up.
So you might be wondering, why does this specific infection take up to 6 weeks to cure? For a standard bacterial infection, you take antibiotics for, a week or two. But with infective endocarditis, the rules change completely. Because of this bacterial fortress we just talked about, the disease demands unusually long treatment courses and surprisingly frequent surgical interventions. I mean, medication alone often just isn't enough when you're dealing with an infection that literally walls itself off from your own immune system.
We actually call this physical fortress of vegetation. When bacteria are seeded into the bloodstream, they attach themselves to the endocardial surface, most commonly on a heart valve that's already somehow damaged or abnormal. Once they attach, they trigger a local host response, essentially hijacking your body's own building materials. They layer themselves with platelets and fibrin to build this structure. The vegetation is, for all intents and purposes, an avascular mass. It has no direct blood supply. This means circulating white blood cells and IV antibiotics really struggle to penetrate it. Bacteria embedded deep inside can survive for weeks, which is exactly why our standard therapies have to run for that massive 4 to 6 week stretch.
All right, in this explainer, we're going to cover 1, the bacterial fortress, 2, mechanisms of peripheral signs, 3, diagnostic updates, 4, treatment and surgery, and 5, mimics and prophylaxis. Okay, let's dive into this. Section 1, the bacterial fortress, and how the infection establishes its base.
So the whole thing almost always starts with a vulnerable heart valve. Maybe it's damaged from rheumatic disease, a congenital malformation, degenerative calcification, or even a prosthetic device. The bacteria find a foothold and the construction of the vegetation begins. And here's the thing, you have to view every single clinical symptom through the lens of this physical mass. Everything that follows clinically, the persistent fever, the emboli shooting through the body, the complex immune reactions, and the eventual need for surgery, is a direct consequence of this fortress. It just sits right there on the heart valve, continuously showering infectious material into the circulation and provoking this chronic, ongoing immune response.
Moving on to section 2, mechanisms. Decoding the peripheral signs of infection.
This brings us to the real conceptual anchor of the disease. Vegetations do 2 distinct things simultaneously. They physically break apart and they trigger chronic antibodies. What's really interesting here is how we can organize every classic sign you've ever heard of into 2 distinct buckets, vascular and immunological. Vascular phenomena are a direct physical emboli breaking off the vegetation. This is what causes splinter hemorrhages in the nail beds, those painless Janeway lesions on the palms and soles, large-scale strokes, and mycotic aneurysms, which, by the way, is a dangerous weakening of the vessel wall from septic emboli, particularly in the brain. On the flip side, we have the immunological phenomena. This isn't physical debris, it's immune complex deposition. This causes Osler's nodes, which are classically tender nodules on the fingers and toes, Roth spots on the retina, and glomerulonephritis, which presents as an acute kidney injury. This perfectly explains why Janeway lesions don't hurt, but Osler's nodes absolutely do.
Let's quickly look at the usual suspects building these fortresses. Streptococcus viridans, Staphylococcus aureus, and Enterococcus are massive players here. Staphylococcus epidermidis is particularly notorious for infecting prosthetic valves. We also have the HASEC group, which are these fastidious gram-negative organisms, but actually it's super vital to note that some cases are totally culture negative. This happens when the infection is driven by hard-to-grow organisms like Bartonella or Coxella, or fungal pathogens, or honestly, simply because the patient was already given antibiotics before anyone even drew the cultures.
Okay, but here is an absolute clinical Easter egg you must commit to memory. If a patient's blood culture grows Streptococcus bovis, it carries a highly established association with colonic neoplasia, meaning finding this specific bug tells you that you must prompt a colonoscopy. It is just incredible how a single microbiology result from a heart infection completely redirects your entire diagnostic pathway straight to the gastrointestinal tract. No way you want to miss that one.
Let's move into section 3, diagnostic updates, modernizing the Duke ISCIV-IDE framework. Historically, diagnosing infective endocarditis relied heavily on the classic Duke criteria. That was a system built largely around standard blood cultures and traditional echocardiograms. But, as you know, medicine evolves. In 2023, the Duke ISCVID criteria completely modernized the framework to match our current diagnostic detective work. Cardiac CT and 18F FDG PET CT are now formally incorporated as major imaging criteria. This is a real game changer, especially for prosthetic valves, where standard ultrasounds just struggle to see past the metal. Metabolic imaging can light up an infection that structural imaging completely misses. Furthermore, intraoperative inspection is now a major clinical criterion, meaning if a surgeon opens the chest and directly sees the vegetation, that counts. The update also expanded the list of typical organisms and brought in newer molecular diagnostics like PCR and metagenomic sequencing. Now, despite all these high-tech imaging updates, good old blood cultures remain absolutely foundational. But the technique here is everything. You need a minimum of 3 sets with at least 10 ml of blood each drawn from separate venipuncture sites at different times. And here is the absolutely critical part. They do not need to be timed to a fever spike. Because the fortress is constantly shedding bacteria, the bacteremia in this disease is continuous, not intermittent. Also, these have to be collected before starting empirical antibiotics. Otherwise, you risk suppressing the culture yield and flying totally blind. Imaging the heart is just as nuanced. Your standard transthoracic echocardiography, or TTE, the ultrasound on the outside of the chest, only has a sensitivity of about 60% for detecting these vegetations. It's genuinely pretty limited for small lesions or prosthetic valves. But transesophageal echocardiography, or TEE, where the probe goes down the esophagus right behind the heart, that pushes the sensitivity way above 90%. So the big takeaway? Never let a negative TTE reassure you if your clinical suspicion remains high. You very often have to push for that TEE.
All right, on to Section 4, treatment and surgery, or basically when to breach the walls. We know empiric antibiotics like ampicillin, vancomycin, or gentamicin are going to run for 4 to 6 weeks to try and penetrate that avascular mass. But when medications are simply not enough, we have to build our threshold for surgery. We certainly don't operate on everyone, but surgery is mandated in very specific scenarios where the fortress is winning. Let's move to and see how this builds. Step 1, refractory heart failure or cardiogenic shock. If the infection has literally eaten through the valve and destroyed the mechanics, antibiotics just can't fix a broken door. Step 2, uncontrolled infection, like an expanding abscess. Step 3, prosthetic valve or fungal endocarditis, because antimicrobials penetrate plastics and fungal masses incredibly poorly. Step 4, persistent fever and positive cultures beyond 7 to 10 days of appropriate therapy. And finally, Step 5, large vegetations. Anything over 10 millimeters with embolic events, or over 15 millimeters period, simply carries a massive physical risk of breaking off and causing a catastrophic stroke. And finally, Section 5, mimics and prophylaxis, protecting the vulnerable. Before we wrap up, we need to talk about recognizing when a fortress isn't actually made of bacteria at all, because not every vegetation on a heart valve is an infection. Merontic or non-bacterial thrombotic endocarditis is a sterile mimic. It's caused by a hypercoagulable state, often linked to underlying malignancies or systemic lupus erythematosus, which you might know as Libman-Sachs endocarditis. The distinction is key here. Merontic endocarditis typically presents with no fever, no white blood cell spike, no new regurgitant murmur, and features much smaller vegetations on the echo. It's an essential differential to keep in mind if the infectious picture just isn't fitting together. Now, to prevent infective endocarditis in the first place, modern guidelines have heavily restricted who actually gets prophylactic antibiotics. You basically need a perfect storm. Step 1, a genuinely high-risk patient. This means someone with a prosthetic heart valve, a history of prior infective endocarditis, or specific congenital heart diseases. Step 2, a high-risk procedure, most notably invasive dental work that manipulates the gums or the root of the teeth. If both of those align, Step 3 is administering standard amoxicillin right before the procedure. However, there is a massive clinical caveat you must remember. Routine gastrointestinal or genitourinary procedures, like colonoscopies or cystoscopies, do not warrant antibiotic prophylaxis under current guidelines. Yep, you heard that right. Even for high-risk patients, we no longer give antibiotics for these routine GI or GU scopes. Well, we've covered a lot of ground today, but if you take away one single thought, let it be this. If you see a patient with a fever, a new heart murmur, a sudden stroke, and an unexplained kidney injury, please do not treat them as separate unlucky problems. Ask yourself if there is one single bacterial fortress quietly sitting on a heart valve, showering physical emboli in one direction and triggering immune complexes in another. Let that unifying concept drive your diagnostics, but it leaves us with a critical, somewhat provocative question.
As bacteria continue to evolve and build fortresses that are highly resistant to our modern antibiotics, will invasive surgery eventually become our only primary line of defense? If this explainer helped clarify the complexities of infective endocarditis for you, please hit that like button. Drop any questions you have about the 2023 Duke ISCVID criteria or the pathophysiology right down in the comments below. Suggest what topics we should decode next, and absolutely make sure to subscribe so you never miss our next explainer. Thanks for joining.